Right, good morning everybody. This is a video recording for the Module 2 seminar about symptoms. This is a really important topic for us in chronic care nursing, and hopefully by the end of the seminar and by also going through the modules, you'll realise how important and fundamental it is to our practice in chronic disease. So what are symptoms? Well, symptoms may or may not be related specifically to a medical problem, and often they have a strong psychosocial element. We know that signs such as blood pressure, weight, urinalysis, temperature, etc., are all objective, observable, and mostly measurable. So they're signs, but symptoms are often not observable. They tend to be perceived and verified only by the person who's experiencing it. And often we can't observe it or perceive it or verify it. So often it's seen as a subjective issue. So common symptoms might be fatigue or weakness, pain. I can't feel somebody else's pain, but it's perceived and verified by that person. Breathlessness, I might be able to observe it, but I certainly, it's difficult to measure. So these are what are considered symptoms. So in the area of symptoms, we often use the term symptom experience, and this is the patient's perception and response to symptoms as they occur. And symptom occurrence then is the frequency, the number of times the event occurs within a given time frame. It might also reflect the duration, which is the persistence or continuance of the prevailing subjective symptom, and also the severity, the amount and degree of discomfort with which the symptom occurs. So overall, we often call it symptom distress or maybe symptom burden. And this is the amount of physical or mental upset or anguish that's experienced from a specific symptom. So just to give you a sense of why I'm particularly interested in symptoms is this is a slide that I use in my research, is that I've compared in the literature those with terminal stages of cancer, who are in the orange, and those with advanced or end-stage kidney disease, which is in the pale blue. And this slide is also, this diagram is also in your module. What it's illustrating is that there are a number of symptoms, and this list can be extended. This is by not all means an entire list of symptoms, but these are generally the common symptoms that you see in most patients with any form of chronic disease, such as worrying, vomiting, change to taste, itchy skin, pain, lack of energy or fatigue, problems sleeping, and so on. So the terminal cancer patients, as I said, have reported against these symptoms, and they're in the orange, so the prevalence. So for example, terminal cancer pain is reported by about almost 75% of people. But if you take a close look at this, there's an interesting thing that you'll see on this diagram, is that those with end-stage kidney disease by and large have a worse symptom burden than those with terminal cancer. So everyone perceives that cancer patients do have a lot of symptoms, and this is where a lot of the knowledge about symptoms and symptom management has come from, is from cancer and palliative care. But what's increasingly becoming clearer to us as researchers and also as clinicians is that people with other chronic diseases also have quite a high symptom burden. And in this diagram, the comparison between those with end-stage kidney disease and their people who are alive, living well, on dialysis, they actually have a worse symptom burden overall than those with terminal cancer. There's only a couple of symptoms where those with terminal cancer have a higher prevalence of that particular symptom, such as worrying, mouth sores, dysphagia, and diarrhea. But all the other symptoms, and particularly some symptoms, are much, much more prevalent or occur more frequently in those with end-stage kidney disease. And I'm going to try and illustrate the symptoms a lot through this module, through this seminar. So what I've just said, patients with chronic disease will have physical and psychological symptoms. And in addition to treatment and its side effect, that also produces various combinations of symptoms. So some of the common symptoms are fatigue, pain, sleep disturbance, depression, change in appetite, change in bowel function, and breathlessness. And these symptoms are fairly common, you know, across heart failure, COPD, and so forth, not just in cancer or even renal failure. So fatigue, as I just said, it's common in many chronic conditions. It's highly subjective. It's very difficult to measure somebody else's fatigue. And it is also multidimensional. It affects many aspects of a person's daily life. And it's difficult to treat. There's no pill for fatigue. There's no medication that can be prescribed for fatigue. So often, nursing and allied health interventions are required to support people to cope with and manage their fatigue. Some interventions might be around distraction, exercise, maybe, and energy conservation, and that's the main one. So if you've worked in rehabilitation areas, you would know that energy conservation is a big component of rehabilitation practice. And so we should be thinking about this when we're caring for patients with various forms of chronic health conditions, chronic diseases, about energy conservation and the strategies we might be teaching patients to manage their fatigue by conserving energy. So the impact of chronic disease is huge on quality of life, and we've looked at this in Module 1. Chronic disease and its symptoms frequently interfere with various aspects of living, such as work life, family roles, socialisation, and just general activities of daily living, being able to self-care. And people with very severe forms of chronic disease also say that they feel depressed, maybe withdrawn, they might be anxious or fearful. So these are also symptoms that affect on quality of life. So compared to healthy people, and chronic disease, particularly as it progresses to worse stages of functional decline, leads to greater impairment of quality of life. And this is often due to depression, anxiety and fatigue, making it very difficult to engage in normal social roles. And you'll find that if you can't engage in normal social roles, which means being able to get out of the house, go to the shops, go to a movie, go out for a meal, go out with family. If you can't do that, it further reduces your quality of life. So this is why there have been several theories around symptoms and symptom management. And I'm only going to talk about the two major ones. There are two others mentioned in the module. But what these theories are trying to do is to conceptualise that total picture of symptom and the symptom burden that affects people. So the theory of symptom management was developed by nurses, and it's used internationally. It's come from the University of California, San Francisco. And here they've developed up this theory that is an all-encompassing theory. It includes the person, the environment in which they live, and their health and their illness parts of their life. And this is illustrated by these circles, but they also overlap with each other. So it's trying to say that the person and where they live and their environmental factors all intersect with their health and illness. And in the middle here is this concept around the symptom experience. It's the sorts of symptoms that you have, your response to the symptoms, how the symptoms might be evaluated, then how they managed, who delivers the care, what sort of management, how much, when is it provided, how is it provided, by who, and why. And then the outcomes. What is the outcomes of managing the symptoms and the symptom experience? Well, what outcomes could there be on their functional status, self-care, costs, quality of life, other diseases, mortality, and emotional status? So this is a really fantastic theory that sort of brings together all of those aspects if you're experiencing symptoms, particularly a range of symptoms when you have advanced chronic disease, particularly like cancer, terminal stages of cancer, terminal stages of COPD, advanced forms of heart failure, and if you've got renal failure, and people with diabetes, the list goes on and on. If you have a chronic mental health disease, you also experience symptoms. And it's not just for people of older age, the same would be true of children with chronic diseases. The other theory is called the theory of unpleasant symptoms, and it's trying to explain how various factors influence the symptoms that are experienced, and then how do the symptoms influence your daily life or your performance. So the three major factors that are considered, if you like, as triggers to the development of symptoms are psychological factors, physiological factors, and situational factors. Again, it's around the person, what's wrong with them, both from a physiological and a psychological perspective, and situational, maybe where they're living, or maybe looking at their role in life. And then all of these interact and may lead to various or cause various symptoms to develop. And each symptom will have its own distress, frequency or timing, intensity and quality. And what this theory is arguing is that there can be any number of symptoms. Okay, N just means continuing on, infinitum, if you like. Not quite infinitum though, but here is a group of symptoms. So these symptoms then influence somebody's performance. And performance can be around function, daily activities, quality of life, and so forth. What this theory also seems to suggest is that if you have a poor quality of life, there is a reciprocal influence back onto these factors, making these factors seem worse, which might contribute to the symptoms getting worse, or maybe the performance, such as a low quality of life, might have bearing on the symptoms. So if your quality of life is low, maybe things like pain and depression and fatigue might be worse, or sleep disturbance. Also, the symptoms themselves might have an influence back on those antecedent factors such as these. So I'll talk more about this theory and does it actually fit the real world a little bit later. So why are symptoms important? Well, they're largely overlooked in routine clinical care, where our focus tends to be on those numbers, the things that we can objectively measure, such as blood results and blood pressure and so on. Symptoms are overlooked because they're seen as subjective, which I've always previously said, that they're related to how patients report them. You know, we ask patients on a pain scale what their pain is like to give us some objective measure, but really pain is experienced by that individual person. So certain people may say they don't have a lot of pain, but to another person, they may have a lot more pain. So that's what I mean about subjectivity. Symptoms, though, are something that we frequently identify. Patients are telling us because we're at the bedside or the clinic chair or wherever we're working, and we're listening to patients and they're reporting their symptoms. But often we can't objectively measure it. However, and this is what I'm going to get onto, we can measure them, and these are through patient-reported outcome measures called PROMs. And increasingly you would have heard about using PROMs more in clinical practice. It's certainly a big push in many, many hospitals across the country to use patient-reported outcome measures. And these tend to capture those subjective experiences. Now, a PROM could be patient satisfaction, but other PROMs can measure symptoms. So I'm just going to give a little bit of information about patient-reported outcome measures and patient-reported evaluation measures. Sounds like research, it is, but it is actually used to measure a whole raft of things, such as I've just said, patient satisfaction with care. So many of you have administered or know that patients get a survey. Hospitals or clinics give a survey to ask patients about their satisfaction with treatment. So it's linked to the Australian Council of Health Standards. It's an important measure of the quality of the healthcare system. So PROMs and PREMs come directly from the patients about how they function or feel in relation to a health condition and its treatment, its therapy. And these are things that are often of greatest importance to patients, not researchers or not medical practitioners, like what is the physiological compounds and the way that a new blood pressure tablet might work, but it's really turning it on the head, asking the patients what's important to them. So often things that are of great importance to patients is that they have knowledge about a disease, and in other parts of our chronic care nursing subjects, maybe in 007, you've looked at patient knowledge and adherence and self-management, so their behaviours. It might be abilities, so functional status, or it might be feelings of well-being, and this is quality of life. Many of you may have assessed patients' quality of life, but you'll notice here that symptoms is part of patient-reported outcome measure or a patient-reported evaluation measure. An evaluation tends to be that they're satisfied with treatment. The rest are outcome measures. So we can collect this using an instrument, a survey questionnaire. It can be generic, such as a quality of life measure, or it can be disease specific, or it can be condition specific. And as I've just said, there's an increasing recognition and use in direct clinical care, but also in research. So getting back to symptoms, we tend to only measure if the person has a symptom, so its prevalence or occurrence. But when we focus only on highly prevalent symptoms, other significant, frequent or distressing or severe symptoms remain under-recognised and unrelieved. So therefore we really need to assess all dimensions of symptoms to help estimate or to recognise the total symptom burden. So if you think back to that previous slide where I showed you all of the, going back, all of the symptoms, this is just measuring prevalence. It's just saying, I have this symptom. But it's actually not saying how frequently this symptom is, how distressing it is, and how severe it is. So this is what I'm talking about, is looking at the multi-dimension of symptoms. So prevalence is one part, frequency, how often it occurs, duration, the persistence, and the severity. And these are all aspects that we need to assess in our patients. If a patient says, I'm feeling fatigued or I have pain, we have to look at not just whether they have it, but the frequency, duration, and severity. So I'm just going to move on to research around symptoms that I've been doing for a number of years now. And a couple of the readings that you have in the module are related to the research that I've been doing, but it's to illustrate symptoms. You might be interested in other chronic diseases, and this is where you can link it to your next assignment number 2. And I'll get on to that soon. But by illustrating using chronic kidney disease, where people have a greater symptom burden than those with cancer, I think it's a very useful learning information. So just as a little way of introduction, we know that around 11% of Australian adults actually do have chronic kidney disease. It is that common. And obviously people who are at high risk of developing chronic kidney disease have diabetes or hypertension or both. They may be smokers are at high risk. As you get older, your risk increases. People with Aboriginal and Torres Strait Islander background have a far greater risk of developing chronic kidney disease than the average Australian population. If you have a family history of kidney disease, you're more likely to develop chronic kidney disease. And also if you are obese. You may not be a diabetic, not all diabetics are obese, and not all obese people are diabetic, but nevertheless, all of these are high risks for developing chronic kidney disease. In fact, we think that 1 in 3 Australian adults are at risk of developing chronic kidney disease. So, most people think of chronic kidney disease as this group of patients who have dialysis or they have had a kidney transplant. And if we use the analogy of the Titanic and the iceberg, the Titanic only ever saw the tip of the iceberg. And that's all most clinicians ever think about in terms of renal failure. It's the last stage of chronic kidney disease. There are, in fact, 5 stages. And it's these other stages below the water, part of the iceberg below the water, where people need to be assessed and monitored for their chronic kidney disease. And we don't want their chronic kidney disease to get worse and get up to the tip of the iceberg. Could you imagine if 11% of the Australian population was on dialysis? Very expensive, okay? And in fact, we do know that by 2030, the rate of people who are going on to dialysis in Queensland will consume the entire Queensland Health budget just for dialysis. So really we should be trying to avoid people getting to stage 5, but that's another story. You can also see this big group of people at risk of developing chronic kidney disease because they have hypertension or diabetes. So this is why we say that chronic kidney disease is hidden. Most people don't realise that it's that common. 1 in 3 adults are at risk and 11% of Australian adults actually do have chronic kidney disease because everybody just thinks of those on dialysis. So what happens when you get chronic kidney disease, and as the it advances and becomes stage 4 and then stage 5, you develop a whole raft of signs and symptoms that affect every system of the body. It is not just the kidneys that are involved with having advanced form of chronic kidney disease. So when you start to understand chronic kidney disease like this, that it is a multisystemic disease. It is not just of the genitourinary system, and it is not just connected with diabetes. In fact, it causes effects on all of the systems. You can now see why people with end-stage kidney disease have a worse symptom burden than those with terminal stages of cancer. Hence why I'm using this as a way to illustrate symptoms. So one of the publications that I've put in the modules is where my PhD student, Haifa Al-Mutari, myself and Clint Douglas here in the school, we examined the literature and identified the most prevalent symptoms, but that symptoms tended to be studied in isolation, only one dimension, looking at prevalence. Generally, it missed the severity and frequency. Often the research had only been done in the dialysis population. Very little was done in other stages. And that a patient-reported outcome measure that was often used to measure these symptoms was called the dialysis symptom index. So what we were interested in was how does symptom burden differ in people with the advanced stages of chronic kidney disease who are on dialysis or who are currently receiving dialysis. So we did a big study to examine and compare the symptom experience. We conducted this study in 3 renal units in adults who had advanced chronic kidney disease, so stage 4 or worse, who are adults and able to give consent. So in the renal world, there are a couple of ways you can measure symptoms. So as I said, the most common has been the dialysis symptom index. But that has only been used on dialysis patients and it needed modification. The other way to measure symptoms, and some of you work in palliative care may have used a POS score, the palliative care outcome scale for symptoms. There's for cancer patients and many other diseases. There's also one for renal. So what we did was we improved the dialysis symptom index and have renamed it the chronic kidney disease symptom burden index. It has quite a number of symptoms and patients can also add more symptoms. And if we compared it to the POS, there's many more. The POS has only been used for those conservative patients, renal supportive care patients, where we could use this in stages 4 and 5. Both of these patient-reported outcome measures measure prevalence and distress, but the POS doesn't measure severity and frequency. So we changed the dialysis symptom index to measure these on a rating scale between 0 to 10, just like a pain rating scale. And most patients are very familiar with a pain rating scale, whereas the POS only uses a 4-point rating scale. Not that familiar to patients. So we decided for our research that this was much more comprehensive. It was multidimensional. It could be used in clinical practice, but also for research, and suitable for different chronic kidney disease patients. But it was long. The POS is simple and quick and easy to use, particularly in the clinical environment, but it really has been only used in conservative managed stage 5 patients. And it doesn't have all of the dimensions. So that's why we developed this, which we modified from the dialysis symptom index. And you can read about it in a publication if you want to. So getting back to our research, we actually researched 436 patients. Now this is a very large cross-sectional sample. Most of them were on dialysis and about a quarter were not on dialysis. So if we look at most were on hemodialysis, some were on peritoneal dialysis, that's the number, 42 were receiving peritoneal dialysis, 69 were in stage 4 and 38 were in stage 5 but not on dialysis. And this is the symptom dimensions. So here we've got the different stages, stage 4, stage 5 who are not on dialysis, stage 5 hemodialysis patients and stage 5 peritoneal dialysis patients. And here we've got the mean scores and standard deviations for prevalence, distress, severity, and frequency. So all of the symptom dimensions. What you can see very clearly is that the prevalence, there's a lot of symptoms occurring. But also the patients are highly distressed, the symptoms are severe, and they occur frequently. But the thing that I've got in red is the hemodialysis patients. If you look at the prevalence of symptoms, it is almost double, and is more than double, those who are not on dialysis, and it is certainly 50% larger than those who receive PD. Looking at distress, it's 3 or more times the symptoms as distressing once you're on hemodialysis, and almost double the PD. Symptoms are so severe, look at the big difference, 19 to 70, and frequent, 3 times as frequent. So, end-stage kidney disease, particularly those receiving hemodialysis, have a much worse symptom burden. And these are the ones who tend to have a worse symptom burden than terminal cancer patients. So what were the most prevalent symptoms? Fatigue, feeling tired or lack of energy. And if you look, 83 and 95% of hemodialysis and PD patients said they were fatigued. Interesting, fatigue was worse in PD patients. Bone or joint pain was also very common, itchy skin, and decreased appetite. These were the most prevalent symptoms. And in our the publication, you can see all of the symptom results. What was most distressing? Out of 10, most distressing again was feeling tired or lack of energy, fatigue. Bone or joint pain, feeling irritable, decreased interest in sex, and itchy skin. There's very little research in patients around sexual symptoms. There is in cancer, but very little in other chronic diseases. This is one of the few studies that has looked at this. Severity. How severe were these symptoms to the patients? The sexual symptoms were the highest. Again, fatigue, bone or joint pain, or itch. You can see a trend happening here. Again, sexual symptoms, feeling tired. So that's fatigue, pain or joint pain, itch, trouble falling asleep, worry, depression, and feeling nervous. They're all very similar scores. So these symptoms, worrying, depression, and feeling nervous, were the only symptoms that seemed to be much higher in stage 4 and stage 5 non-dialysis, whereas all the other symptoms and severity and frequency and distress and so on were much more, were higher in the hemodialysis and the peritoneal dialysis patients. It's not surprising that those in stage 4 and stage 5 who are not on dialysis would be feeling worried or nervous and might even be depressed about living with their renal failure. So we've published that as well, and I think that was one of the readings. I can't remember all of the readings that I put in the module. So the patients seldom present with a single symptom, and this makes perhaps explain why you're trying to treat one symptom may not necessarily improve somebody's quality of life. So what the cancer world now look at are symptom clusters. And this is where 2 or more symptoms that occur together, which are stable and relatively independent of other clusters, so there are 2 or more symptoms that are tightly associated with each other. And they may or may not share the same etiology. So if we look at the characteristics of a symptom versus a symptom cluster, symptoms are subjective, may vary over time, they have antecedents. So what's going to likely be the trigger factor? And going back to the theory of unpleasant symptoms, those trigger factors were physiological, psychological, and situational factors. The symptom will influence outcomes such as function, performance, quality of life, those sorts of things. They may be influenced by an intervention. So, for example, with pain, you give some analgesia and to alleviate the pain. And often there's an underlying mechanism. So in cancer or in renal failure or in heart failure, often the symptom is associated with some physiological reason. So these are very subjective. Whereas symptom clusters have the same characteristics as a symptom, plus there's 2 or more concurrent symptoms and they're stable. They group together in a strong way and they're independent of each other. But they may have shared underlying mechanisms. They may have shared outcomes. So what we say is that there's a sort of a bigger temporal dimension to symptom clusters. But why is symptom clusters important? Well, it's a better way to assess a patient, and if you can assess for one symptom, you're likely to know that there will be other symptoms clustered at the same time. So if you're assessing for fatigue, are there other symptoms that also happen when a person is fatigued? If you can do that, you can prioritise assessment and management by targeting the clusters that strongly predict patient outcomes. And what it will lead to is better interventions and hopefully improve somebody's quality of life. So the majority of knowledge and information that have occurred to guide clinical practice has occurred in oncology, in cancer patients, and looking at symptom clusters. And there is research that's informing the practice in cancer around how to manage these symptom clusters and the effect that by managing them well will have on functional status, quality of life, and in fact, mortality rates. So if symptoms are well controlled, a cluster of symptoms are well controlled, then there is evidence to say that a mortality rate is slower. So the time to death is longer, if you like. And that time is seen in people having a better quality of life and more able to do things. So the research that I've done with Hafer and Clint, I'm the senior researcher, so that's why I'm last on this authorship, is that we looked at, are there symptom clusters in people with advanced chronic kidney disease? And what we found from that earlier research with the 436 patients is that there are in fact 5 symptom clusters in chronic kidney disease. The first cluster is around fluid volume symptoms. So if you have one of these symptoms, you're more likely to have the others. So for example, shortness of breath. You're more likely to have these other symptoms, and they're all related to fluid volume. Makes sense. Neuromuscular symptoms that closely clustered together are muscle soreness and numbness and tingling. Sexual symptoms, which I've already mentioned, psychological symptoms, and gastrointestinal symptoms. But you think, there's a few symptoms that are actually missing. Well, what we found was fatigue didn't fit into one symptom cluster, which is really unusual. It actually fitted in all 5 symptom clusters. If you think back to my earlier slides, fatigue, feeling tired and weak, was the most common symptom that was coming through. It was prevalent, it was distressing, it was frequent. and severe. So our research has found for the first time why people with advanced chronic kidney disease have such severe fatigue, worse than cancer patients. And it's because it's such a common symptom, it's ubiquitous, and it clusters or it links with all of the other symptoms. And it shouldn't have. It should have clustered only in one cluster. But also we found that restless legs and sleep disturbance also clustered in the fluid volume, the neuromuscular, and the psychological symptom cluster. And that makes sense. If you've got restless legs, you're going to have sleep disturbance, and you're more likely to have psychological symptoms. You might be anxious, depressed, worried, stressed, those sorts of things. So this is one of the few studies in the world outside of cancer that has looked at symptom clusters. There's very few. There's a couple in heart failure. There's one in COPD. There's very little else in any other chronic disease. So and this is one of the few studies in renal disease. It's really going to help us understand how to better manage symptoms as a group of symptoms. And this would hold true for other chronic diseases with symptom clusters, just like they did and have been doing for probably almost a decade now in oncology. So getting back to the symptom theory and the theory of unpleasant symptoms, these theories that you have in your module and the two that I've just mentioned, well, they are associated with people just thinking about a theory. What makes logical sense? But are they really tested? Do they fit the real world? So what we did, we tried to test the theory of symptom clusters against the theory of unpleasant symptoms. So the psychological, physiological and situational factors in our research are the psychological factors associated with that symptom cluster that I've just mentioned, the age of the patient, the stage of their chronic kidney disease, and their comorbid conditions. And this is what we found was influencing the symptom experience. This is the symptom experience in the theory. So what we found was these three factors, stage of CKD, age and psychological, were the most influencing factors. And they influenced it nearly 70% of the time. So we could predict that stage, age and psychological factors were the ones that were going to predict whether people had worse symptoms. What we also wanted to know was which of the symptoms that we'd found contribute the most to the symptom experience. Fatigue, not surprisingly, contributes the most. Fluid volume, also the same amount. And sleep disturbance was very close. But you can see the other numbers here. Not important that you know the numbers, but you can see that they were very high and contributed to the symptom experience. Go back to the theory. The last part of the theory is how do the symptoms influence performance? So in our research, the performance we measured through quality of life. And this is our quality of life results. And there was a strong influencing in the same direction as the theory affecting performance, which we measured as quality of life. And it occurred in almost 60% of patients. So it's very strong theory. So what we have been able to prove is most of the theory. what you'll remember in the theory is that there seemed to be a link from performance or quality of life back to these influencing factors and also back to the symptoms. We haven't yet been able to prove that, but certainly the main parts of the theory does seem to fit people with chronic kidney disease. Now, I know there's a lot of numbers in there. It's not important. What I'm trying to illustrate is that the theory of unpleasant symptoms, which was really designed for cancer patients, does seem to fit with our chronic kidney disease patients. So presumably, it will also fit with heart failure. So now, very briefly, I'm just going to touch on a couple of other chronic diseases and look at their symptoms. So symptoms such as shortness of breath, fatigue, edema, and changes in sensation are very common in in heart failure patients, as well as psychological symptoms such as depression, feeling anxious, chest pain, and gastrointestinal. And as you can see, most of those symptoms are very similar to those with chronic kidney disease. Hence why I use that as a way to illustrate symptoms. So, with heart failure, while there's no cure, early diagnosis, lifestyle changes and appropriate drug treatments can help patients lead normal and active lives, stay out of hospital and live longer. And self-efficacy or giving patients the confidence to manage their symptoms is really important. That's why there's a lot of heart failure clinics, heart failure clinical nurse consultants, heart failure nurse practitioners to help manage patients with heart failure. So the goal of symptom management in heart failure is to prevent heart failure developing and slowing the progression, prolonging life, maintaining as much left ventricular function as possible. The goal is obviously to keep the symptoms such as breathlessness and edema and things like that under control, improve physical activity, and all of those things should improve quality of life, as well as reduce hospital admissions. Now, I know that was a bit of a quick run through, but it's to illustrate that symptoms are common between many chronic diseases and the management is very similar. I want to thank Professor Terry Green for these slides and look at some stroke symptoms, which tend to obviously be related more to the neurological damage that's been suffered during a stroke, such as weakness or numbness or paralysis, difficulties speaking or understanding, dizziness, loss of balance or unexplained fall. Remember, it's very hard to objectively measure these symptoms: loss of vision, sudden blurring, headache, and difficulty swallowing. So often with a stroke, it may be related to intracerebral hemorrhage, and patients often describe it as like a thunderclap headache, and the worst type of headache in the world. We all know we should be observing for stroke symptoms, such as drooping of the face. Can the person lift both their arms equally and have strength? What is their speech like? Is it slurred? Do you understand the person? And then obviously time is very critical to get some help. And if you click on the links in the slide, it will take you to the Stroke Foundation information, and you can look up this work and get some more information. So in stroke management, it's about rapid assessment, and by doing that, it facilitates appropriate diagnosis and then early intervention. And the most important part of nursing care is to monitor blood pressure, temperature, and blood sugar. Really important that they are all monitored accurately, and so that these can be responded to quickly to avoid further damage. Good screening and assessment, particularly around the severity of the stroke. What is a person swallowing like? What is their mental function like? And then coordinating and reinforcing lifestyle and secondary prevention, because secondary stroke can occur. So a key important part of nursing care for stroke patients is obviously interdisciplinary, multidisciplinary work, making sure that patients have appropriate care pathways, and maybe that care pathway might be to palliative care, and obviously very important to involve carers such as spouse and family and friends who are provided with adequate discharge information and training. So just to sort of sum up then, the management of chronic disease really must include the assessment for symptoms. So it's not just about objective clinical signs. And then the goal of care is to reduce patient symptom burden. And just remember that when you assess for symptoms, that symptoms are multidimensional. It's not just whether you've got a symptom or not, so the presence or absence, but also the frequency, severity and distress related to that symptom. The other important thing apart for our practice is that we need to be aware that symptoms are likely to cluster together. And if one of the core symptoms from within a symptom cluster is identified, then it is likely to include the other symptoms in that cluster. So, for example, if a patient has muscle soreness, think about a cluster of symptoms related to neuromuscular. So nurses ought to anticipate other symptoms, and so you need to intervene for the entire symptom cluster. And early recognition of a cluster of symptoms will facilitate appropriate intervention, so that you might be targeting one symptom, but it's likely to target a multiple of symptoms and could then lead to better patient outcomes and more efficient use of healthcare services. So, why is Module 2 important? Well, it is. It's not just a module around Anne's research or Anne's passion of renal disease. It's actually what we do as nurses every day when we assess patients. So this is why it's part of your second assessment, which is your case study. One component in your case study is that you have to identify 3 pertinent signs or symptoms. Remember, the patient will have 3 chronic diseases, not just 2 like assignment 1, but 3. And then you will identify which signs or symptoms, they could be either, could be all 3 signs or all 3 symptoms or a mixture, it doesn't matter, but I want you to explore why these ones are of particular significance to those multi-morbid patients with 3 chronic diseases, and explain how these signs or symptoms then contribute to the actual patient issues or problems, and that leads on to the final component around your nursing intervention. So Module 2 is crucial for assessment number 2 as well. So thanks very much, and as always, contact me if you have any questions about the modules, the content and the assessments.